Okay, perfect. And thank you also for the opportunity to talk about the research we do on perioperative care. So let me start first by defining what is perioperative care. And this is the care given to a patient before, during, and after surgery. The problem is that, as we saw also in the quiz, about 70% of the patients undergoing surgery suffer from serious postoperative complications. And the situation can be exemplified by this schematic graph, where you have three patients that are seems to all doing fine, but they start deteriorating. And while patient A recovers quite quickly and patient B takes a bit more time but still recovers, patient C does not recover and will probably be sent to the ICU and hopefully will be still on time to save the patient life. And indeed, up to 20 million people annually require intensive care unit admission and mechanical ventilation. And mechanical ventilation is definitely a life-saving technique that can help critically ill patients to reduce their breathing effort and recover. However, it's also often defined as a necessary evil because although it's a life-saving technique, it has important potential complications. And these include, for example, ventilator-induced lung injury. It also contributes to post-ICU syndrome, which is long-term physical, cognitive, and mental health issues. It can lead to oxygen toxicity because, yeah, as too high CO2 can be dangerous, also too much oxygen can be dangerous. And it's also associated with the atrophy and or dysfunction of the diaphragm muscle, and also with a complication is the occurrence of patient ventilator asynchrony that leads to a lot of risk, including the one I just described. And patient ventilator asynchrony can be defined as the mismatch between the patient respiratory demands and what the ventilator is able to deliver. And in particular, I would like to define times of patient breathing. So the time that the patient starts the inspiration, the patient ends his start the expiration here. And in a dashed line, we see when the ventilator starts triggering, so it pushes air into the patient lung, and when it stops pushing air. And when these timings are not well synchronized, then we have a patient ventilator asynchrony. And PVAs are associated with increased risk of lung damage, longer need for mechanical ventilation, and longer ICU stay, and also increased mortality. And the many methods have been tried to reduce the occurrence of patient ventilator asynchronies, but adjusting the ventilator settings in an optimal way seems to be the most effective solution for reducing patient ventilator asynchronies. So in this talk, I would like to describe the research we do for timely prediction of postoperative deterioration with the goal of allocating the patients to the appropriate level of care in time, and on our efforts to improve our understanding, prediction, and classification of patient ventilator asynchronies with the goal of optimizing mechanical ventilation. So let me start with the first topic. This is the graph I showed before. And we want to help clinicians predict on time which patient will need more remote, more close monitoring. And in the hospital, we have a wealth of data available. So we have patient history and comorbidities or habits. We have lab values from blood tests. We have vital signs available that are acquired during surgery or in the recovery room, called also PACU. And what we wanted to investigate is whether we could use this wealth of information to provide a timely warning and predict in advance which patient will need an ICU admission. And to do so, we performed a study at the Katerina Hospital in Eindhoven, where we collected data from the electronic medical records from all surgical procedures between 2013 and 2017, only excluding some procedure because they had a different protocol in the postoperative care. And we collected data from all perioperative stages. So from the preoperative screening, comorbidities, age, BMI, habits, data during surgery, including the type of surgery, narcosis, the duration of surgery, vital signs, and so on, and also from the recovery room. And what we were interested in, so when a patient goes to surgery, there are two possible pathways after surgery. The first pathway is that the patient is admitted directly to the ICU. And this is not really interesting for us because this is either done standard because the surgery is particularly high risk or the patient is particularly high risk, or no standard because deterioration has already been predicted during surgery. So this is not something that we can improve. What we would like to improve is this situation. So on the right, you see the normal path, the ideal path that the patient goes to the ward, to the surgical ward, and then after a few days is discharged home because he's doing fine. But what we don't want to happen is that the patient goes to the ward because we think everything is fine, but then is admitted to the ICU because it's deteriorating. So this unplanned ICU admission is what we want to predict. So these are our cases and these are our controls. And you can see already that the number is quite different. So it's a small number compared to the controls. And I'd like already to give credit for this work to Tom Backes and Evelyn Meston, that are two PhD students working on this topic. And especially I'm going to focus on the work of Tom, that is investigating machine learning algorithms to predict unplanned ICU admission. And in this study, we looked at a few machine learning classifiers, among which the logistic regression that is often used in clinical practice, and also Bayesian networks, random forest, and support vector machine. And the Bayesian network was used because we thought we could include domain knowledge by asking the clinical expert to construct this network. And because of the very unbalanced data set with very few cases compared to controls, we adopted a nested k-fold cross-validation. So ideally, when you train a statistical machine learning model, you would like to have a training set to train your model, a validation set to choose the best model, and then a separate independent test set to evaluate your performance. But when the data is so unbalanced and so small, then this is difficult to achieve. And so what we did is to divide the data set in a test and training set, and then the training set was further divided in a test and training set. And this inner loop we used to do feature selection and parameter optimization for the model. And once we had the best model, this model was then tested on this partition that was not used for model training. And this approach, this nested k-fold cross-validation, has been shown to be conservative in the evaluation of performance. And here are the results. As you can see, most machine learning classifiers perform quite well, except for the Bayesian network, and with the results that are significantly lower than the other. This could be because for the Bayesian network, we did not perform any feature selection because the network was fixed by the clinicians. And it can also be that being a more complex machine learning algorithm may need more data to be able to perform well. But among the other classifiers, we achieved very nice performance. I focused in particular on the area under the curve because given the high imbalance, if we will look at accuracy, any even a naive classifier simply predicting that no patients will have a deterioration, then will already give a very good accuracy. So the area under the curve is more balanced performance. And we see that with the SVM, we could obtain very promising results. In the second, and we also look at the feature importance because one of our goals is, of course, to perform what we call interpretable machine learning, because we want to provide clinicians with insights on which aspects are more important, which aspects should be monitored more closely when we want to predict patient deterioration. And what we see here are the top features, top 10 features for all the classifiers. And an interesting result is that all the best performing classifier used as top features a feature from all the operative stages, suggesting that looking at the data from all the stages is very important to provide an accurate prediction. In the second part, I would like to discuss our research efforts in mechanical ventilation. And we have different goals. The first goal is to automatically detect and classify PDAs. And we do this by deep learning, so a very data-driven approach. But on the other hand, we also want to understand better the interaction between the patient and the ventilator. And we do this by modeling this interaction. And besides providing a better understanding, this also gives us the possibility to produce simulated data sets that then can be used to improve our detection and classification on outpatient ventilator asynchronous. On the other hand, we also want to use data-driven methods to further improve our modeling. And this, again, can be used to further improve the detection and classification of PDAs. And I will explain in the next few slides how all this comes together. And again, I want to give credits to the students that are working hard on these topics, Anouk and Liming and Tom. I put them close by their respective research, but they collaborate very tightly to make all this happen. And first, let me define what is an asynchrony, or better, the different types of asynchrony. So we talk about inspiratory and expiratory asynchronies. In particular, among the inspiratory asynchronies, we have delayed inspiration when the difference between the patient starts breathing and the mechanical ventilator triggering is too large, larger than a certain threshold. And then we have late cycling instead of expiratory asynchrony, when the difference between the patient's start of expiration and the cycling of the ventilator is too large. And then we have an early cycling, which is the opposite. So when the ventilator stops too early compared to the patient expiration. And finally, we also define effective effort, which is a bit different because in this case, the mechanical ventilator doesn't sense any patient effort, so it doesn't start the mechanical inspiration. And we can also describe this asynchronous on this kind of plot, where we have on the y-axis the expiration delay and on the x-axis the inspiration delay. And of course, all these points here where the delay is small, they are normal breaths. And anything outside of this are asynchronous. And we can see that in this case, we can also have combinations of asynchronous, such as the delayed inspiration late cycling in this part of the graph, or a delayed inspiration early cycling in this part of the graph. And to develop an automatic method for detection and classification of asynchronous, we performed a study in collaboration with the Policlinico San Matteo in Italy on 15 patients for a total of more than 4,000 breaths. And we had available air pressure, flow, and volume curves given by the ventilator, and also labeled data by a clinical expert. And a label means that this clinical expert looked at with the use of an esophageal catheter, they could accurately measure the patient breathing effort, and they could accurately find where the patient starts his inspiratory effort and stops his expiratory effort. And we developed a UNet network. So we modified it because UNet was originally developed for analysis of medical images, and therefore the input was 2D, and we adapted to input 1D signals. And here is a schematic of the network architecture. And also in this case, we performed cross-validation, but we used a leave one out approach where we train the network on 14 patients and we test on a patient that is left out. And then we repeat this for 15 times so that each patient is once in the test set. And to analyze these waveforms, we used a moving window where we look at 10 seconds of the signal, which includes about 5 breaths. And then the window is moved of about 5 seconds and so on. And here I show an example of the results. Here you see the mechanical on and mechanical off, which are given by the ventilator. So these are known. And what we try to predict is the inspiration and expiration from the patient. And once we detect this inspiratory and expiratory moment, then we can define, detect and classify asynchronous based on the delays between these two time points. And here we see the comparison of the ground truth, the plot I showed before, with each point representing a breath, and what we predicted with the neural network. And although there are some wrong predictions, in general, the areas with normal breath and asynchronous seems to match quite nicely. And when we look at the numbers, we also obtain very high accuracy for all the asynchronous and especially very good true positive rate and true positive, true negative rate. However, the study has some limitations because we perform this validation only on 15 patients and we didn't have an independent data set, so we could not really evaluate the generalizability of our method. And this is in general a very big challenge because it's difficult to obtain a good quality clinical data set with annotations. And especially for ventilator data, to have a good quality data set with annotations, you often need invasive catheterization to obtain the esophageal pressure. And you need a clinical expert that looks at these waveforms and put these labels, which is a very time-consuming and labor-intensive task for people that are normally very busy already. And so we asked ourselves, how can we improve on that? And we thought we could create a simulated data set by modeling the interaction between the lung and the ventilator. And so we developed two models, one for the ventilator and one for the lungs, based on an electrical equivalent. And with this model, we could simulate different patient archetypes because we could simulate the healthy patient using values for the parameters of the model based on literature. But we could also change these parameters to simulate different disease conditions, or like obese patients, patients with RDS or COPD, and patients with fibrosis. And here we see some example of the simulated waveforms compared to the clinical data. And we see the healthy with the clinical data, they have a very nice match, and we can also simulate different patient archetypes and also some different asynchronous. And the beauty is that now we have the ground truth automatically because this data is simulated. Then we know exactly when the ventilator starts and ends, and when the patient starts and ends his breathing. And so to validate our simulator, we perform some tests. The first question we ask is, can clinicians tell the difference between the real waveforms and the simulated waveforms? And so we proposed a survey to 16 experienced clinicians where they were looking at 32 different examples, 16 simulated and 16 clinical waveforms, and they were presented randomly. And they had to choose whether they were real or simulated. And the result is that only 53% of the waveforms were classified correctly, which basically means it is equal to a random guess. Translated, the experienced clinicians were not able to distinguish between clinical and simulated waveforms. Next, we asked, can I tell the difference between the simulated and clinical data sets? And so we used the UNet that we developed for detection and classification of asynchronous, and we tested this network on the simulated data set. Well, the results we obtain are lower compared to the clinical dataset, but that's understandable because the clinical data, the network was trained on a dataset that included only 15 patients with a limited variability of the condition that they had. So our simulated dataset has much larger variability and might include patient archetypes that have never been seen by the network. So finally, the next question we asked is, can the simulated dataset improve our detection of patient ventilator asynchronous? And so what we did to test this is to train the neural network on a mix of clinical and simulated data. And here I show the results for the ratio 1:1. And we tested on the clinical dataset. So when you compare the results, this one I showed before, that were obtained by training on the clinical and tested on the clinical dataset, with the results obtained by using also the simulated data in the training, we see that for each asynchrony and normal breath, the results are either equal or better. And even though the improvement is marginal, this suggests that it's a very promising approach to use a simulated data set to increase the availability of a labeled data set. So final question that we ask is, can we improve the simulations so to further improve the detection and classification of asynchrony? And to do so, we're investigating generative adversarial networks. So this type of networks are being used, for example, to produce fake images out of nothing. And the idea is that you have a network that is a generator and another network that is a discriminator. And these two networks, they compete with each other. So the generator is input mostly noise and produces an image. And the discriminator needs to be able to discriminate between a real and a fake image. And as the generator gets better and better at producing real images, the discriminator gets better and better at discriminating between real and fake. In this way, they can get very good performance. And I'll show you here an example. If you look at this website, we see this person that is fake, it doesn't exist. It was created by this generative adversarial network. And so we thought, how can we use this for our goal? And the idea is that we input a generator simulated data for which we know the labels. And we use clinical data because we do have a lot of clinical data, but it's unlabeled. And hopefully the generator and discriminator will be able to finally output more realistic simulated data. And so this is more in detail our VentGAN framework. We have a simulator that produces synthetic data. This is input to the generator. And we also have a label real data. And the goal is to make this synthetic data more similar to the real clinical data. And very briefly, I won't go into the details, but of course, to train a neural network, you need to define a loss. And the adversarial loss and discriminator loss, as I kind of mentioned before, they kind of fight with each other. So the network obtain the best results when these are start to be balanced. But in this case, we also added two different kind of losses, the L1 loss and the soft edge loss, because besides wanting to have an output that is very similar to clinical data, to real data, we also want to maintain the labels. So the time annotation in the simulated data should not change. And to assure this, we compare the generated data with the simulated data, and we have an L1 loss to reduce the differences between these two. And we also input the generated data and simulated data to the UNet model. And if the time annotations are still the same, the output of the UNet model should be the same for these two data sets. And with these two laws, we try to force the network to maintain the time levels. And this is an example of waveform that we obtain. Here you see in red the original simulated data, and then in blue the data after has passed through the generator. And you see new features in this waveform that probably are due to make this simulated data more similar to the clinical data. Of course, the next step is to verify that these changes in the waveforms will actually improve our detection and classification of asynchronous, but this is still work in progress. So finally, I would like to conclude by describing what we're working towards. About the timely prediction of postoperative deterioration, we are looking also at methods to predict deterioration on the ward. And we want to investigate whether we can obtain similar results when we have a more difficult case, because of course, on the ward, there is a much more infrequent data collection with respect to the surgery or the recovery room. Also, we have a simulator, a model of patient and ventilator interaction. And we want to see whether we could use this model to accurately estimate the breathing efforts in different scenarios, and use this knowledge to guide towards lung protective ventilation. Finally, we want to improve mechanical ventilation, and ideally, you want to have a method that automatically classifies the asynchronous, and based on the type of asynchronous, takes action to optimize the ventilator settings. And for this, we are investigating reinforcement learning. And briefly, reinforcement learning, you have an environment and an agent, and you want the agent takes some action to improve the environment according to a certain criteria. And if the action taken improves towards the criteria, then we have a high reward, otherwise a low reward. And this way, the agent learns how to take the right action in the right state. And similarly with the asynchrony, we would like to have once we detect and classify an asynchrony, we would like the agent to learn which action to take to reduce the number of asynchronous. And with this, I'd like to conclude. And of course, I'd like to thank you all for the attention and all the collaborators involved in the research. Happy to take any questions.
Thank you, Simona, for this really nice presentation. I already see Wacht raising his hand. So Wacht, start off asking questions.
Quite a few questions, mostly on the first part, the ICU part, and patient going back there. So my first question is, you say, I really don't look at the patients who directly go to the ICU because I'm not interested in them. But they would say they probably send patients to the ICU who don't have to go there, and they find that out later. So you might actually learn from that too. Did you consider that?
Yeah, that's a good point. We actually consider that both because if you have these patients that are admitted already in the ICU, but it's not planned, it means something happened during surgery or before that warned the doctor. So you can find similarities between the patient that they go to an unplanned ICU admission and those that actually go to planned ICU admission. So this could be also used. And a good point that we could also focus on those that did not need to have an ICU admission. But then the problem is, how do you define your ground truth? How do you know that it didn't know to go to the ICU?
To know when a patient really physically has to go back, you're sure about the case. That is clear.
Yeah.
Okay, yeah, clear. Then I have another question, because you gathered all these data, and my experience is they come from all kinds of different systems. So to use such a model in real life might be tricky. Did you look at, okay, how we can minimize the data set we need?
It might be tricky, but there are in recent years more and more effort to improve this, to have a more integrated system where you have the data collected that is all in one system. But no, we didn't really look exactly at the way to use data only from, let's say, the EMR or from the surgery, or no. We didn't.
But then the question, so your model, so your really model helps already preventing people to go to the ward who actually should go to the ICU. But since the set is already so unbalanced, how many people would you actually send to the ICU who do not have to go to the ICU? Because that will also be the result of your model. And it will point to a number of people who actually don't have to go. So I cannot.
Yeah, that is the
Because
number
that's
of,
such a much
let's say,
bigger group.
false positives. That's the number of false positive, but in our results, I think it was quite low.
Yeah, okay, but since the group is so big, it might still be a lot of people. So is this percentage-wise? I couldn't quickly see this in the numbers.
No, well, the group of unplanned ICU was quite small. It was the opposite
I mean
problem.
the group of the people who just go to the ward. If even if you send only a small fraction of those who do not have to go to the ICU, even if it's only a small fraction, it might still be a lot of people. And
yeah, indeed.
Talking about cost and stuff like that, huh?
Yeah, indeed. Well, we don't look at accuracy, as I mentioned, because it's so unbalanced that then you would basically decide either not to send anybody to the ICU. But yeah, I didn't look exactly at the number of false positive, but that's something to look into. Yeah.
Thank you.
Of course, ICU admission are expensive, and we also want to.
No,
also
so
want
that's
to make
why
sure that.
You prevent this, but you cost me another.
Yeah, but and sometimes it's also that you don't send them to the ICU. It's just you take a bit more care in the recovery room, or you know that the patient needs to be monitored more closely on the ward. It doesn't have to be an ICU admission.
Then on predicting which patients to do, and I couldn't quickly see it on all the features you use. Did you also use features of the doctors? Because I'm pretty sure there are doctors who are less good in stitching than others. So there will be doctors where more patients have to go back than others. So
okay. Which doctor performed the?
Yeah.
No, we didn't look at that.
Okay.
Maybe I wouldn't. Yeah, it's a good suggestion, but I wouldn't look at the individual doctor. Maybe years of experience would be more.
But doctors know. The rest, the same as with researchers, there is a difference. Okay, thank you.
Yeah, good point. Didn't think about it.
Yeah, following up on that, I wondered if you have a small patient group in the first part. It was only 223 patients, but I can imagine that the type of surgery you have might also be linked to the chance of deterioration or complication. It's maybe not only the surgeon that can do better suturing, but also the type of surgery that you underwent. Did you take that into account?
Yeah. So first of all, some high-risk surgery, they're not in this research because they were excluded because they have a different post-operative care. Some patients, they go to the ICU as standard after high-risk surgery, but also the type of surgery was one of the features.
Okay, I didn't see that.
Well, I guess share it again quickly. And is not in the top 10. So this seems to suggest that the type of surgery is not really important.
Okay. I'm not sure if Carola is still there, but I saw that she was raising her hand.
Right. Yeah, we had some discussion here. We're at a full group here. So thank you, Simone. Wonderful lecture. And actually, we did the quiz together, of course. We were discussing actually what is the temporal resolution of the EMR data, and would increasing the temporal resolution actually add to the prediction? And we're still wearing mouth masks in the hospital, so that is why you can't see all our faces.
I don't know exactly what is the resolution, also because there are different variables. So there are categorical variables, there are waveforms, there are all kinds of data. So I think
but for the vitals, because we are here, the vitals group, so we're very interested in the mechanical ventilation and the vital signs, actually. What is typically?
The mechanical ventilation was quite high. I think it was 1,000, was it 1,000 hertz? Maybe Tom can intervene because he knows better all the details about the data.
But if you go to the ward, because if you go to your first study that you did with your group, it was on predicting the unplanned ICU. And there you have the data in the ward. So then it would be typically the early warning score collected data to use also data.
We used some waveforms from the surgery, but not the all waveforms. We took summary statistics from the waveform, like a minimum or maximum heart rate and so on. So we condensed the data in this sense. So we didn't fully exploit the full waveforms.
Okay, thank you for the answer. It's
Yeah.
still very for us a very our studies relate to your studies, so I'm interested in
And a bit smaller patients.
yeah, a bit smaller patients, but in some more information. But we will talk to you later about the
Yeah.
similarities in our studies.
Gladly, yeah.
Are there any other questions from the audience? Maarten.
Yeah, thank you, Simona, for a very nice presentation. Yeah, I was wondering myself, because now you looked at the best use of the data which is there. But did you also think of, let's say, ways how to improve, let's say, increase the data, which could help reduce the false positives and false negatives?
Yeah, we are thinking about better exploiting all these waveforms that are available during surgery. Well, now we'll only use maybe minimum or maximum of a whole waveform in a very large time. But other than that, we also want to look at lab values, because we didn't look at that. So blood tests and results of lab values. But yeah, other than that, not. But if you have any suggestion, of course, it's very welcome.
Well, yeah, I would be interested in, let's say, if you have an idea in which patients where the failures were. Let's say if you can get some common, let's say.
Yeah. Well, for that, we were actually collaborating with the visual analytics group. We would like to better understand how the algorithms making a decision and where this subpopulations were failing or not, and why.
Yeah.
Yeah.
Indeed, yeah, because it may help you, of course, to define better, yeah, additional ways of monitoring. Yeah.
Yeah.
Okay, thank you. That was very clear.
Are there any other questions? In the meanwhile, I have a question. I'm completely not an expert on ICUs and patients, but I can imagine that your breathing frequency, although you might be in ICU, is not always constant. And there can be an accidental occurrence that you get this change in the frequency. What gives what's the signal then that this is asynchrony before the patient goes back to his regular breathing pattern?
It's always, for asynchrony, it's always the difference between the patient starts breathing and stops breathing, and the mechanical on and off. And normally the mechanical ventilator is triggered by the patient effort. So if the patient effort are faster for some period, also the mechanical ventilator should keep up and provide a faster respiratory rate. So yeah, that's the way.
Okay, Maarten, your hand is still raised. Do you have another question or?
No, sorry.
Okay. And I saw in the part of Anouk that you take flow, volume, and pressure. Is there a role for frequency also? Because I can imagine that the patient who is more obese or has COPD has a higher breathing frequency compared to a healthy patient.
I think that's more of a consequence of all these parameters and how they change, how the muscle, the lung characteristic change in this kind of patients. And then, of course, we simulate different respiratory rates also for all the different types of patients.
Okay, I see that Carola is still like having their own discussion. It's really nice to see. Are there any other questions? No, if not, then I would like to thank Simona again for this really nice presentation. As you know, Simona, there will be a small gift from the center to thank you for this really nice presentation. For the people in the audience, I would already announce the next Care and Cure Cafe due to May holidays. This will be on May 13th, and this will feature Liesbeth Janssen from Applied Physics. Location and time will be sent to you around April to let you know. But please make a note in your agenda that the meeting will be on May 13th. And so I would like to thank Simona again for participating today, and I wish you all a really nice weekend. The sun is shining, so enjoy some outdoor time, and I hope to see you soon face to face.